I bring Dilini on, I'll just read out a quick bio about her education history. So Dilini graduated with a Bachelor of Science majoring in Vision Science in 2015 from the University of New South Wales. She then graduated with a Master of Public Health from the University of Sydney in 2017. And she has been working with Macular Disease Foundation as an education officer since she has graduated, providing all non-clinical support that a patient, family member and carer might require. Dilini also has previous experience working with volunteers at the Cancer Council, offering training and support. So now I'd like to formally hand over to Dilini.
Hi everybody, thank you so much Natasha for that introduction. My name is Dilini, as Natasha mentioned, and I'm part of the education team at the Macular Disease Foundation Australia. And today we're going to be going through intravitreal injections or eye injections or IVI. I do have a bit of a disclaimer before we begin. The advice and the information we're providing today, it is quite general in nature. So if you do have a very specific question or a personal question, we do recommend that you ask your healthcare professional, and we also recommend that you ask your healthcare professional before following any of the advice that we provide today. So today's program, we're going to be going through wet or neovascular age-related macular degeneration. We're also going to be going through intravitreal injections or IVI, the Pharmaceutical Benefits Scheme or the PBS, Medicare, the Macular Disease Foundation's advocacy work before we touch on COVID-19 and intravitreal injections. So why are we here today talking about wet or neovascular AMD? Well, AMD is actually very common in Australia. 1 in 7 over the age of 50 have some form of the condition. And out of these 1 in 7, there's almost 51,000 who are receiving treatment for neovascular AMD. Now, while that 51,000 number is from a 2017 report, it's only expected to increase with the aging population that Australia has. Okay, so before we look at neovascular or wet AMD, I just wanted to quickly touch over what the macula is. So on the right of your screen there, you'll be able to see an image or a cartoon of an eye that's just been cut in half. So at the front of the eye, we have the pupil. This is one of the first structures that light passes through when entering into the eyes. Secondly, we have the lens. So the lens, it's similar to the lens of a camera. It helps focus the light that's entering into our eyes. So as I said before, light, it will enter through the pupil. It will go through the lens, which will focus that light before the light travels through the vitreous. Now, the vitreous is a clear jelly-like substance that holds the shape of the eye. Now, after light passes through the vitreous, it's going to hit a layer of the eye called the retina. So you may be able to see a red layer at the back of the eye. So that's all the retina. Now, when light hits the retina, that light is absorbed, and then those light messages are taken to the brain through the optic nerve, and that's how we see images in our everyday life. Now, part of the retina is a very, very small section called the macula. You might be able to see it here. It is quite small, so it's a bit difficult to see, but you may be able to see a small indentation in that green circle there. So that's the macula. Now, the macula is responsible for all of our central vision and about 90% of our visual processing. So this means things such as reading, writing, driving, even recognizing faces, that's all done by the macula of our eye. So quite an important part of the eye. Now, if we move on to the image to our left there, some of you may have seen an image like that at the optometrist or maybe even at the ophthalmologist. That image is called a fundus photo. And this is actually an image of the back of the eye. Now, again, in green, I've just circled the macular region of the eye. So you can see a slightly darker patch in the middle there, and this entire section is known as the macula. So now that we know what the macula is, let's look at age-related macular degeneration, or AMD. Now, AMD is split into 3 distinct stages. There's an early stage, an intermediate stage, and then a late stage. And the late stage is divided into 2 different types. There's the dry or atrophic type, and then there's the wet or neovascular type. Now today, we're going to be focusing on that late wet or neovascular type of AMD. So let's take a closer look at that. So what we're going to do is we're going to zoom in on the macula. So as you can see on the image here, we're just going to take this little square there and we're going to zoom in. Now on the image to your left, you may be able to see some cells of the retina sort of to the right of the image, and then we have some blood vessels to the left of the image. Now on the next slide, when we look at wet or neovascular AMD, what I'm going to do is I'm just going to flip this image on its side. So that's the same image there, we've just flipped it. So again, for wet or neovascular AMD, we have some cells of the retina up the top. You may be able to see a yellow section in the middle there. That's the buildup of waste product or drusen. That's very, very typical of AMD. And then at the bottom, we have some blood vessels here, and you may be able to see that some new blood vessels have grown through the back layer of the eye, and that's what happens with wet or neovascular AMD. Now, these blood vessels, because they're new, they tend to be quite weak and they can leak blood and fluid into the back of the eye, and that's why it's called wet, because there's literally fluid sitting at the back of the eye. Now, if we look at some fundus photos of what this looks like, so on the left, this is a healthy eye here, and on the right, you might be able to see a sort of dark brown, black, red patch in the middle there. So that is that blood and fluid leakage that has occurred for this patient with neovascular AMD. Now, if a patient does have neovascular AMD, the gold standard treatment is intravitreal injections, or IVI. Now, IVI is a treatment where medication is injected directly into the vitreous, or that clear jelly-like substance of the eye. And it's used for many conditions, including neovascular AMD. Now, the purpose of the injections is to try and stop the growth of abnormal blood vessels and to try and reduce that fluid leakage that's occurring. And the earlier that treatment is started, the better that the outcomes may be. However, if left untreated, conditions such as neovascular AMD can lead to significant loss of central vision and even blindness. Okay, so if you are receiving IVI or intravitreal injections, what can you expect? So first, let's look at the IVI schedule. Now, most Australian ophthalmologists practice something called treat and extend. So this is where they'll provide loading doses. So typically that's 1 injection per month for the first 3 months. And then they will try to stretch out the time period between injections. So instead of saying, you know, come back in 4 weeks, they might say come back in 5 or come back in 6. Now, some patients will be stretched out even further than that. However, other patients will remain at the 4 weekly intervals. Your interval is very, very dependent on the individual, and it's also dependent on the advice of the ophthalmologist. Now, typically, intravitreal injections for neovascular AMD will most likely be lifelong unless advised by your ophthalmologist. Secondly, effectiveness. So intravitreal injections are the most effective treatment that's available for neovascular AMD. Like I said, it's the gold standard. Now, a study found that over a 5-year period, 2/3 of patients reported a small improvement in vision, or they reported that their vision stabilized. So that's quite successful. Now, the purpose of these injections is to try and maintain vision. So if you are receiving treatment, but you haven't noticed an improvement, that doesn't necessarily mean that the injections are not successful. If your vision is maintained, that's considered a measure of success. And finally, compliance. So it's really, really important that treatment is not discontinued unless on the direct advice of your ophthalmologist. Stopping treatment may result in significant loss of vision, and vision loss occurring after stopping treatment may be permanent, even if you decide to restart the treatment later. If you do plan on stopping treatment, we really do encourage having a chat with your ophthalmologist first. So now let's move on to something a little bit different. Let's look at the government services that are associated with things like intravitreal injections. So first, I wanted to touch on the Pharmaceutical Benefits Scheme, or the PBS. Now, the Pharmaceutical Benefits Scheme was initiated to provide timely and affordable access to medications for Australians. And under the PBS, the government subsidises the cost of most medical conditions, the medications for most medical conditions. So just to clarify, the PBS looks after the cost of drugs and medications, while Medicare looks after the cost of medical procedures. We'll be touching on Medicare a little bit later. So in relation to intravitreal injections, there are 2 major drugs that are used in Australia. One is called Eylea, and the other one is called Lucentis. Eylea and Lucentis are registered with the Therapeutics Goods Administration, or the TGA, and it's also registered with the Pharmaceutical Benefits Scheme, or the PBS. And as a result, the patient co-payment for Eylea and Lucentis for concession card holders is $6.60, and for non-concession card holders, it is $41.30. Now, there are 2 other drugs I'd like to touch on as well. So the first drug is called Beovu. This is a fairly new drug. It was recently registered with the TGA and the PBS. It's covered by the PBS for use in patients where Eylea and Lucentis have not worked for them previously. And then, of course, there's Avastin as well. Now, Avastin is not registered with the TGA, and it's also not covered by the PBS for eye injections, and it costs approximately $50 a dose. Some ophthalmologists may decide to use Avastin, especially for patients who are not eligible for the PBS. Now, the PBS has something called the safety net. So the PBS safety net comes into play when a patient pays above a certain threshold for their medications. And again, I'm going to stress here that we're looking at medications rather than medical procedures. So under the PBS, the thresholds that you can see on the screen there for concession card holders is $316.80, and it is $1,486.80 for those non-concession card holders. So once a patient co-payment accumulates and reaches these respective thresholds, then patient co-payments actually reduce. So I said initially that a concession card holder will pay $6.60. Once they reach this threshold, they're actually going to pay $0 for their Eylea or Lucentis dose. And then for non-concession card holders, it goes from that $41.30 all the way down to $6.60. So essentially, once you reach these thresholds, the cost of medications will reduce down to $0 and $6.60 for concession and non-concession card holders, respectively. So that's the PBS. So that was all about the drugs and medications that are used for intravitreal injections. Now, let's look at Medicare. So Medicare is a little bit different. It is Australia's version of universal healthcare, and it helps Australians with the cost of their healthcare. Medicare also provides rebates for procedures associated with intravitreal injections, and it provides rebates for patients. And rebates are essentially the money that you receive back from Medicare for the procedures that you are undergoing. Now, on this table, you may be able to see a number of different items. So let's just go through this. So we've got item numbers. So those are numbers that are given by Medicare for particular procedures, and the procedures are defined in the description here. We have a Medicare scheduled fee. So this is just an arbitrary number defined by Medicare for particular item numbers. And then, of course, we have the benefit or the rebate. So the benefit or the rebate is how much that you will receive from Medicare for each individual item. And the way that it's worked out is the benefit is 85% of that Medicare scheduled fee when you receive treatment in room. So if you're receiving treatment privately in room, you will receive 85% of the scheduled fee for each individual item. Okay, so let's go through each of the items individually. So initially we have item 104. So this is for the initial consultation or the first appointment that you have with your ophthalmologist. We've got 105. So this is for every single consultation after that first appointment. The next two item numbers, we have 11215 and 11218. So these are listed for angiograms, so for one eye and two eyes respectively. Angiograms are essentially x-rays for your blood vessels. So they can show weakened blood vessels, they can show fluid leakage and even blood clots. And generally, angiograms are conducted towards the beginning of your treatment, and it's done for the purposes of diagnosis. The next item number we have is 11219. That is for optical coherence tomography or an OCT. Now, an OCT is a scan of the back of the eye. And this may be done to diagnose neovascular or wet AMD, and it may also be done before each individual intravitreal treatment. All right, so looking at the next two item numbers, we have 42738 and 42739. Now, both of these item numbers are associated with the injection fee, with the latter also including anesthetic. Now, for intravitreal procedures, intravitreal injection procedures with anesthetic, this is usually applied by anaesthetist, and it's likely to be done in a day surgery setting. So there are a couple of little things that need to be noted with these item numbers, a little bit of fine print. So the first one that we're going to look at is item number 105. So the subsequent consultation. So for item number 105, a rebate is not provided for a consultation if it is conducted on the same day as an intravitreal injection procedure. However, if it's conducted on a different day to your treatment, then the normal rebates apply. The next one I want to look at is the last two item numbers, so the injection fees. So that could be either item number 42738 or 42739. Now, if two eyes or if both eyes are injected on the same day, the second eye receives 50% of the rebate that's listed. However, if each eye is conducted on a different day, so say my right eye was conducted on Monday and my left eye was done on Wednesday, then the normal benefits apply. And finally, I also wanted to talk about the OCT. or item number 11219. Now, for OCTs, OCTs can only be reimbursed for an initial diagnosis to confirm the eligibility for a PBS-funded eye injection with a maximum of 1 reimbursement per year, which means that the first OCT they conduct for you to diagnose your neovascular AMD will be rebated. However, the remainder of the OCTs that they conduct before your intravitreal injections will not be rebated back. So that's it for Medicare and the individual item numbers. Now, similar to the PBS, Medicare also have a couple of safety nets associated with it. So let's go through those safety nets now. So the first one I wanted to look at was the original Medicare safety net, or the OMSN. Now, the OMSN is only for non-hospital medical items. So, and it's all concerned about the gap amount. The gap amount is the difference between the Medicare schedule fee and the Medicare benefit. So we're going to be looking at this, so the Medicare scheduled fee, and we're going to be looking at the benefit or the rebate that we receive, and we're looking at the gap amount as well. So how we calculate the gap amount, actually what I'll point out first is we're going to be looking at item number 42738, which is that injection fee. We're going to keep this consistent and keep looking at the same item number here. So the Medicare scheduled fee for the injection is $310.15. The rebate that we receive from this item number is $263.65, which means the gap amount, so we're taking 310 and then we're minusing the 263, and we're left with $46.50. So that is your gap amount. Now, once the total gap amount for all non-hospital Medicare items exceed the original Medicare safety net, that means that instead of receiving the $263.65, the original Medicare safety net will give us $310.15 as our rebate. So once we reach a safety net, we get a little bit more back from Medicare, and that $310.15 is how much we get back instead. Now, total gap amounts are calculated in a calendar year, so it restarts again every January. The threshold that we have to receive for the total gap amount is $481.20. And this is regardless of whether you're a concession card holder or a non-concession card holder. This is the gap amount, the total gap amount we all need to reach to gain a benefit from the original Medicare safety net. So let's move on to the second Medicare safety net, which is known as the extended Medicare safety net. And this is a little bit different. This, instead of looking at the gap amount, this is going to be looking at your out-of-pocket costs. And the extended Medicare safety net is probably one of the most important safety nets for people receiving intravitreal injections, because it does give the biggest rebates back. Okay, so again, we're going to look at another example here. So we'll look at, again, item number 42738, which is that injection fee. I've just put in the ophthalmologist fee at $500 there, which is highlighted in the red. The benefit that we're receiving for that item number is $263.65. So that's how much money Medicare is giving back to us, which means that our out-of-pocket expenses that you'll be able to see here is $236.35. Now, that is the amount that we're paying out of our own pocket. So after Medicare gives us a rebate back, we have to pay that additional amount out of our own pocket. Now, I have listed this out in a slightly different graphic, which may be a little bit easier to digest. So this whole amount we have here is the ophthalmologist fee of $500, the $263.65. That is how much Medicare is giving us back. That is that rebate amount. And therefore, we have $236.35 left, which we are paying out of our own pocket. So as I said before, the extended Medicare safety net is looking all at these out-of-pocket costs. That's what it revolves around. Now, the extended Medicare safety net says that once your total out-of-pocket costs for all non-hospital Medicare items exceeds a particular threshold, then you will receive a further benefit of 80% of your out-of-pocket expenses. So, sorry, I know that's a bit of a convoluted sentence, so let's try and break that down completely. So we'll look at the same item number again, so 42738, which is that injection fee. And again, I've put the ophthalmologist fee at $500. As we discussed before, the rebate associated with that is $263.65, and our out-of-pocket expenses is $236.35. So these are all the numbers before we have reached our extended Medicare safety net. Once we've reached our threshold or that safety net, then we get further money back. We get a further rebate from Medicare. And that further rebate is actually 80% of this out-of-pocket expense here. So we need to do a little bit of maths to figure that out. So our out-of-pocket expense is $236.35, and that further rebate is 80% of that. So as you can see here, I have 80% of those out-of-pocket costs, which is 80% of that number that's highlighted in orange, which equals $189.08. So that $189, that's the additional rebate that Medicare is going to provide for us. So now let's go back to the beginning and let's try and figure out, after we've reached our threshold, what do our out-of-pocket expenses look like? So again, this does take a little bit of maths, but what we're going to start off with is, so like I said, the out-of-pocket expenses after we've reached our threshold. So we'll start with the ophthalmologist fee again, which I have here at $500. We're going to minus that original rebate that we're receiving, which is $263.65. Then we're going to minus the additional rebate that we receive after reaching that threshold, which is $189.08, which is then going to leave us with $47.27. So that $47 amount, that is how much we're going to be paying out of our own pocket after we have reached that extended Medicare safety net threshold. So if you compare those amounts, so if you look at the number highlighted in orange, so that $236.35, and then you compare it with the $47.27, that's quite a big difference in how much we have to pay out of our own pocket. Okay, now I have been talking a lot about these thresholds that we have to reach, and the thresholds are really dependent on if you're a concession card holder or if you're non-concession card holder. So it's dependent on the individual. So if you're a concession card holder, then your threshold is $697. If you're a non-concession card holder, then your threshold is $2,184.30. Now, there are a couple of things to note here as well. Again, a little bit of fine print. So the first thing I'd like to note is only items which attract a rebate contribute to these thresholds. So if we look at an example, If, say, I'm at my third intravitreal injection appointment and an OCT is conducted before I receive the treatment, that OCT, because it does not attract a rebate, it does not contribute to these thresholds. Even if I'm paying that out of my own pocket, it does not contribute. The second thing I'd like to note is these thresholds are calculated through the calendar year, which means, again, in January, it restarts the tally. And finally, the last little thing I would like to touch on here is that you can actually combine your significant other or the rest of your family onto the extended Medicare safety net together so that you reach the thresholds quicker. So if you're an individual and you don't have any dependents, there's nothing else that you need to do. You'll be automatically registered for the Medicare safety net. However, if you have a significant other or families, then we would really encourage you to register together. Like I said, it just means you may reach that safety net or that threshold a little bit quicker. And this applies even if you're all on the same Medicare card. Now, if you would like to register for the Medicare safety nets together as a couple or as a family, registration is free and you only have to do it once in your lifetime. And it's quite easy to do. So you can either download a registration form from the Human Services part of the government website, or you can call you can visit a Medicare service centre, or you can call Medicare's helpline, which is 132011. If you are a DVA Gold Card holder, you may actually qualify for additional rebates, including OCT scans. So just make sure to research that and see what you're eligible for. Okay, now moving on to advocacy. So I just wanted to talk about some of the advocacy work that the Macular Disease Foundation has done around all the government services and rebates that are provided. So first, I wanted to look at stopping the intravitreal injection rebate cut. So in 2019, the Medicare Benefits Scheme Review Task Force proposed to cut the rebate for intravitreal injections with a formal recommendation given in 2020. So the Macular Disease Foundation, we rallied support from the macular disease community for stories and personal experiences around intravitreal injection costs. And we also worked with other eye health stakeholders. We ended up funding and developing 2 PwC reports to provide the economic impact evidence of an intravitreal rebate cut on not just the patients, but on the government as well. And we discussed this with the task force members directly during the consultation phase, and we're having ongoing discussions with the federal, state, and territory health ministers. Currently, the federal government has not yet made a decision on this recommendation, but we will continue with our advocacy efforts to make sure that the intravitreal injection rebate is not cut. Secondly, I wanted to look at the OCT rebates. So the Macular Disease Foundation has campaigned for OCT rebates for many, many years. And due to our efforts, OCT rebates were introduced in November 2018. Prior to that, there were actually no MBS rebates for OCT scans. Currently, OCT rebates are only available for initial diagnosis, but we're going to continue our efforts, our advocacy efforts to make sure that MBS rebates for all required OCT scans are met. And finally, increasing public and bulk billed intravitreal injection treatment. So historically, the first medication for wet or neovascular AMD was introduced onto the PBS in 2007, with the second medication listed in 2012. Now, the Macular Disease Foundation supported both PBS listings, but due to systemic issues, patients could not switch between the two medications. So we rallied our community for our switching campaign in 2012, and we successfully got switching approved in the same year. Now, currently, public access to intravitreal injection treatment is definitely an issue in Australia, with the vast majority of treatment provided by private ophthalmologists. And public treatment is very limited and primarily located in major cities. Our advocacy efforts, we continue to advocate to try and increase the availability of intravitreal injection treatment in public hospitals, and we're exploring initiatives to encourage bulk billed private treatment and to improve the fee transparency, and also to empower patient and their self-advocacy. Now, before I finish, I did also want to talk about COVID-19 and intravitreal injections, given that the time we're in, I think it's quite an important topic. So first of all, if you are receiving eye injections for neovascular AMD or diabetic macular edema or any other retinal conditions, it is essential that you continue to receive your regular treatment. Even if you're in a state where you're in lockdown, intravitreal injections are considered an emergency procedure. So you are allowed to leave your home. You will not get fined for leaving your home for this particular treatment. The federal government stated aim is to vaccinate as many Australians as possible against COVID-19, especially those who are most vulnerable. And there is no contraindication or additional precautions to receiving the vaccine for those undergoing intravitreal injections as well. The Macular Disease Foundation, we strongly recommend that if you are eligible to receive your COVID vaccination, please get it as soon as possible, unless you've been advised otherwise by your healthcare professional. Now, if you are receiving intravitreal injections and you do have some concerns about getting the COVID vaccine, please just have a chat with your treating doctor and they will provide you with some recommendations. All right, so that brings me to the end of my presentation. Thank you very much, everybody, for listening in. I hope you found that informative, and I'm just going to now hand it over back to Natasha. Thank you so much.
Thanks, Dilini, that was great. So I might just go to a few questions now that have been coming through. Just a reminder again, if you have any burning questions, you've still got a bit of time. Remembering to answer them, or sorry, type them out in the questions box. So it's the fourth icon down that dark grey bar, type them out in the white box and then send them through to us. At the conclusion of this webinar, we will be sending out a survey, and the survey is just a really good way for us to get feedback on the webinar education topics. We can send you out a fact sheet on understanding the costs and rebates associated with the eye injections, which will go over all the content that Dilini covered in this presentation. You can also access previous webinars and also future webinars through that survey. And just a little plug before we go to the questions for the next webinar coming up. Associate Professor Peter Van Wijngaarden from the Centre for Eye Research Australia will be presenting on diabetic eye disease. And that will be on Wednesday the 14th of July from 2 to 3 p.m. And to register for this event, can you please email education@mdfoundation.com.au and we will register you for that particular webinar. Okay, so now I might get Dilini back on the screen and I'll start going through all these questions. Okay, let's see. So there were quite a few questions coming through about the concession card rates. So I know Dilini spoke about the different thresholds for concession card holders and non-concession card holders. So I thought I just would answer this one for you, if that's okay. So to be eligible for the concessional threshold, you need to actually hold one of a few different cards. So that might be the pensioner concession card, the Commonwealth Seniors Health Card, a healthcare card, or a DVA white, gold, or orange card. So there are a few different state and territories that issue a seniors card. The seniors card won't mean that you're eligible for the concessional threshold. It has to be a Commonwealth Seniors Health Card. So just keep that in mind. To apply for the concessional cards that I just listed out, you do have to go through Centrelink or Department of Veteran Affairs for those DVA cards. Okay, so that would apply for all the PBS thresholds, but also the Medicare thresholds that Dilini spoke about. And just to clarify, there's a question here, Dil, if you wouldn't mind going through it. What is the difference between PBS and MBS rebates in terms of what they cover?
Yeah, so the PBS, or the Pharmaceutical Benefits Scheme, that is all around the medications or the drugs that are used. So Pharmaceutical Benefits Scheme, it's all about the drugs. Medicare is looking at the medical procedures that are associated. So if we take intravitreal injections as an example, at your appointment, the consult that you're having with the ophthalmologist, the process of the ophthalmologist putting the injection into your eyes, the OCT scan, those are all considered medical procedures and they're all covered under Medicare. The only thing in that appointment that's going to be covered by the PBS is the drug that they're using. So that might be Eylea or Lucentis in most situations.
Great, thank you. And the Medicare schedule fee that you spoke about, does that change each calendar year as well?
Yeah, so not just a Medicare schedule fee, but the thresholds, the rebates, all of those can definitely change, not just in a calendar year, sometimes it can change even more frequently. If you do have a specific question about that, you can definitely give MDFA a call. If not, on our website, we do update that regularly, but yes, it does change.
Great, thank you. And one final question here. I'm receiving OCT regular payments of $80. Is there a way of receiving a benefit from Health Fund? Hard to see, received an injection a couple of hours ago.
Right. So I'm not completely sure about an OCT, but just in general for all the item numbers, some private health insurance companies do provide rebates for intravitreal injection associated procedures. It does depend on the provider, and it does depend on your level that you have with that provider. I would encourage just giving them a call and asking what is covered, and then if some of those item numbers are covered, then you will need to go to an ophthalmologist that will take private health insurance. So that could be either in a private hospital or a day surgery setting, and then you will receive rebates for that.
Great, thank you. I think that pretty much covers all the questions. There's a final question here about how we access the handouts. So the presentation slides won't be available, but I will just remind everyone the survey that we'll be sending out at the end. You can opt in to receive this eye injection costs and rebates fact sheet. So this will cover everything that Dilini spoke about in the presentation. If you do have any further questions, you can always call our 1-800 number, which is on the screen, and you can ask to talk to Dilini, myself, or any of the other educators. And that number again is 1-800-111-709. Okay, so that concludes all the.
Sorry, just to butt in, Natasha.
Okay.
So this webinar will also be recorded as well. So while we won't have the presentation available, you can re-watch the webinar on our website or on YouTube.
Good on you. Thanks, Dilini. Okay, thank you everyone so much for your attention. Thank you so much, Dilini, for sharing all your knowledge today. And yeah, thank you so much for joining us.
Thanks, everybody.